year with a topic near and dear to my heart, which is the prevention and management of hepatitis B in people who inject drugs. So one of the reasons I think this patient population deserves special note is that people who inject drugs really do have a higher burden of hepatitis B infection. In the United States alone, it's estimated that about 2.2 million adults are people who inject drugs. And among the age group of 18 to 40-year-olds, injection drug use is the most common risk factor for hepatitis B acquisition in the United States. And this graph here just gives you a little bit of a comparison about both the exposure prevalence and the detectable surface antigen prevalence in people who inject drugs compared to the general population. And what you can see is there's really a dramatic increase in prevalence of Hep B exposure among people who inject drugs compared to the general population. And similarly, those with evidence of ongoing replication with detectable surface antigen here, nearly 20 times higher in people who inject drugs. And as one can imagine, this is largely a result of increased risk of exposure, either through percutaneous exposure with shared injection materials, syringes, spoons, cotton, where blood products can be transmitted, but also potential for a high risk exposures through unprotected sex, transactional sex, incarceration, and homelessness. In addition, there are a number of barriers to care, both from a health system standpoint and a political standpoint, that really drives this disproportionate burden and infection and prevents patients from obtaining the preventative care they need. And really, prevention of hepatitis B in people who inject drugs is a key component of the hepatitis B elimination plan. The World Health Organization highlights prevention of hepatitis B in people who inject drugs as one of the 5 key components to successful elimination. And the United States seems to be on track with achieving one of their 2025 goals to have a greater than 25% reduction in new hepatitis B cases among people who inject drugs. And this is largely based on extrapolating the trends in acute Hep B seen between 2017 and 2019, suggesting we're on track to achieve that goal nationally. However, I do have concerns, as I'm sure a number of you do, in the setting of the expansion and explosion of the opioid epidemic, as well as continued inadequate access to care, fueling a lot of these increases in hepatitis B infections observed on more regional levels. And I'll highlight just 2 scenarios here, which I think are really impressive. And the first group here is between 2006 and 2013, we see a tremendous increase in the number of acute hepatitis B infections in a region of the US really devastated by the opioid epidemic in Appalachia. So we see Kentucky, Tennessee, and West Virginia have a dramatic increase in acute infections compared to an overall trend in the general or in the rest of the United States where the rates were decreasing. And what we can see is really this is overlapping tremendously again with opioid epidemic, but West Virginia alone has a tremendously higher rate of acute hepatitis B than anywhere else in the United States. And so looking a little bit more at the West Virginia experience, in 2016, the rates were the highest in the United States for acute hepatitis B infection. And again, I sound like a recording here, but really has a tremendous overlap with the opioid epidemic. We can see here there's a tremendous increase in both acute hepatitis B as well as acute hepatitis C, overlapping with the number of opioid deaths. And really in a lot of the investigations done in the studies from the prior slide, as well as this, again, injection drug use was the predominant risk factor, and over 75% of people reporting risk factors as well. So really offers an opportunity to jump in with preventative interventions in this high-risk patient population. And that was done. And so, since we still see these rates increasing, we have to think about what are the additional barriers to providing high-quality care to people who inject drugs. So really just taking more of a global perspective of looking at common barriers to care for people who inject drugs. I've grouped them largely into four global pictures, and substance use disorder, both with opioid use, alcohol use disorder, as well as non-injection drug use, really a predominant barrier to patients becoming linked to care or engaged in care. Additional economic barriers are likely overlapping patients who inject drugs, and this can be job instability, food insecurity, homelessness, as well as frank poverty. Incarceration is a major issue in the engagement and retention of care as well. And the stigma that not only hepatitis B has associated with it, but all of these other factors as well really exacerbates or has a layering effect on people who inject drugs, preventing them from seeking care. And so when providing care for people who inject drugs, I think the best successful model is really having a multidisciplinary approach. And this is, again, more globally speaking, having people, both your clinicians on site, pharmacists who can assist with medication refills and patient access applications, having our social workers available to connect with patients and overcome any additional barriers to continuation of care within that center, as well as addressing comorbid mental health needs, engaging peer counselors and nutrition, particularly with food insecurity, to really make sure that the whole person is being treated during their engagement in care. So thinking more about patients who inject drugs as they present to care, I'll go through a few scenarios of the screening assays. I know we've reviewed these on prior sessions, so I won't belabor these points, but really just to say that all people who inject drugs need hepatitis B screening. And those screening assays should be the surface antigen, core antibody, and surface antibody. And one profile, if they're all negative, those are non-immune patients and really have the opportunity to offer vaccination. So while talking about vaccination, really want to nest that in the idea of unique aspects to prevent hepatitis B in people who inject drugs. It's worth noting that people who inject drugs have a lower coverage of Hep B vaccination, which is really unfortunate, but as I mentioned, given all the barriers, not necessarily surprising. Since hepatitis B, at least the recombinant vaccine, has been available since 1986, we do see that the prevalence of vaccine-induced immunity is less than that in the general population and among people who inject drugs. Almost about 15% in one estimate, compared to about 22% seen in the general population. And there have been a number of studies trying to find ways to increase access and awareness of hepatitis B vaccine. And really the summary statement comes down to making sure that hepatitis B vaccine is available at all points of care access, whether it be in urgent care, emergency rooms, STD clinics, during incarceration events, to make sure, as well as syringe exchange programs, to make sure patients or people who inject drugs are provided that preventative intervention. There are a number of different hepatitis B vaccines available. 3 of the licensed single antigen vaccines include Recombavax and Engerix, which are both 3 series shots at 0, 1, and 6 months. Heplisav, approved in 2017, is a recombinant Hep B vaccine with adjuvant, and so decreases the number of shots needed. And in a study done by Rosenthal, looking at the cost-effective strategies to providing vaccination for hepatitis B in high-risk patient populations, really found that the use of Heplisav B was most cost-effective for people who inject drugs as a means to complete that vaccination series. And in addition, we see that there's a suggestion that Heplisav has a higher seroprotection rate compared to Energex as well, so may offer additional coverage. The most recent vaccine is a 3 antigen vaccine called Prehevbrio, and I saw Thomas on, so please correct me if I'm not pronouncing that correctly. But approved as of last month. And so this is a vaccine available at the 0, 1, and 6 months as well. Similar to the Heplisab, seems to have a higher seroprotection rate and may provide earlier seroprotection or higher seroprotection in interval injections as well. And to be complete, I'm including the combination Hep B, Hep A vaccine or Twinrix, which is similarly a 3-dose series. So additional aspects of prevention that are worth mentioning in this patient population really focus on harm reduction, so preventing transmission of hepatitis B. I think sterile syringe programs are probably no surprise. 2 highlights, I think, in the Philadelphia area where I'm at is Prevention Point, which is really the first physical sterile syringe program, offering both exchange of syringes and syringe access on site and through mobile clinics or mobile distribution. Another such program, Angels in Motion, also offer mobile access, and so really trying to bring these resources to patients where they are. Other options include counseling on the safer injection practices. So if patients are unable to access single-use syringes, new syringes, there are mechanisms to decrease risk of transmission through disinfection. And this little graphic here is the 9-step process to cleaning your syringe and needles provided by the CDC. In Pennsylvania, needles and syringes are available over the counter without a prescription, and so you can get a box of 100 needles and syringes for anywhere between $15 and $30. But again, that may be cost prohibitive in a lot of these patients. And most, I think, exciting in the last couple of weeks is the opening of the first safe injection sites in the United States in New York City, in the neighborhoods of East Harlem and Washington Heights. Really, the experience both in British Columbia and at European safe injection sites is this decreases overdose death and really offers an opportunity for this marginalized patient population to be engaged in care. So we looked at the profile for patients who need vaccination. To be complete, we'll just again highlight some of the other serologies you'll see. So in patients who have no reactive or no detectable surface antigen, but positive core antibody plus or minus surface antibody, again in the setting of screening, reflects prior exposure and generally speaking does not need additional testing. But really from the screening perspective, those who have reactive or detectable surface antigen really warrant that comprehensive evaluation with additional laboratory and fibrosis assessment. So let's focus now on the management of hepatitis B in people who inject drugs. When people present to your clinic as an initial visit and you find that they have a detectable surface antigen, important just to delineate or distinguish if this is an acute infection or chronic. And acute is defined as surface antigen within the first 6 months of detection here. And so what would support the presence of acute infection is seeing that positive IgM for anti-Hep B core. In this patient population, they may be asymptomatic, but in about perhaps 30%, they may present with an icteric hepatitis. So they may be jaundice, they may have liver aminotransferases in the thousands, but may not necessarily be need to be admitted to the hospital. However, if there is evidence of coagulopathy, encephalopathy, or any concern in a patient population that has poor social support, would have a low threshold to route them to the hospital. As we know, approximately 1% will have fulminant liver failure. So among patients who have persistence of their hepatitis B surface antigen for over 6 months are really defined by that chronic hepatitis B infection. And in adults following that acute infection, approximately 5 to 10% will develop a chronic infection. And so these people are the ones that have that persistence of the surface antigen as well as core antibody and e-antigen or e-antibody here as well. And that really speaks to the next stages of, pardon me, these also are patients who are maybe totally asymptomatic or have mild liver aminotransferase elevations here. So what are your next steps when you identify patients who have a detectable surface antigen for more than 6 months? How are you thinking of managing them here? And one option would be to refer to your local hepatologist or an infectious disease subspecialist. And this, one of the highlights or what are the nice aspects of working with people who have an investment in management of any of that. Okay. Of people who inject drugs are, there's often the ability to offer a warm handoff to the other care team and identifying practices that are quite responsive to the unique care needs of patients who inject drugs, both by making sure that they're not turned away if they're 20 minutes late, making sure that they're connected with additional social work services, transportation needs, things along those lines. But for those who this may be an insurmountable barrier to get to a subspecialist, really understanding what the full laboratory assessment and fibrosis assessment needs are is important. So here's a little table of what I generally get for patients with detectable surface antigen and concerns for chronic hepatitis B infection, looking at hepatitis B E antigen, E antibody, DNA levels, as well as hepatitis delta antibody, knowing people who inject drugs have a higher prevalence of hepatitis D or delta co-infection. Again, owing to the common routes of transmission, screening for hepatitis C, screening for hepatitis A immunity. Again, in Philadelphia, we had outbreaks of hepatitis A through parenteral transmission because of, in the setting of people who inject drugs. So really an opportunity to vaccinate against Hep A as well. Screening for HIV, and then obtaining a baseline comprehensive metabolic panel, a complete blood count, and PT-INR. Fibrosis assessment is also important, and while historically liver biopsy has been the sampling diagnostic gold standard, elastography is largely preferred, and this gives you a sense of vibration controlled transient elastography or FibroScan available. If that's not available, and again, it's another insurmountable barrier for your patient population, there are lab-based testing that are reasonable to obtain. FIB4 is recommended by the WHO in resource-limited settings, so you would have that calculation available with just this full laboratory assessment. And other proprietary assays such as FibroTest may be an option if that elastography is not available. So treatment of people who inject drugs with detectable surface antigen, really the same as people who don't inject drugs. And this is snipped directly from the treatment guidelines. And so really no dramatic difference in how you would treat somebody or how you would approach somebody for hepatitis B treatment based on their E antigen serologies and DNA levels, as well as the any evidence of elevated aminotransferases here too. Again, these gray areas are a number of additional caveats or nuances to the management, but these are also people that you're going to be monitoring serially as well to evaluate for any evidence of progression of disease or transition from a monitoring period to a treatment period as well. What I will highlight is that in people who inject drugs, there's also the opportunity to offer HIV prevention. And this is a scenario where I really do reach for tenofovir disoproxil fumarate as opposed to tenofovir alafenamide. And that's because we know tenofovir disoproxil fumarate-based pre-exposure prophylaxis for HIV can also treat hepatitis B as well. And in people who inject drugs, TDF or TDF-based regimens are the regimen of choice, and when taken regularly can reduce the risk of HIV by about 74%. Medication assistance for either uninsured or uninsurable patients are available. The usual resources I go to for TDF, FTC, or Truvada, CDC PrEP Access has a very detailed flowchart about how you can you or your patient can access PrEP. Gilead Advancing Access as well has options there. And then for tenofovir alafenamide or Vemlidy, also available through Gilead Advancing Access. I think it's important in this patient population that may have challenges to retention and care to counsel them on a low but potential risk for hepatitis B reactivation with abrupt stop of therapy. And this is, I would argue, more theoretical than what we see regularly, and drawing from the data from HIV PrEP trials where the risk is low, but warrants clinical monitoring for the rare but potentially concerning evidence of reactivation and overt hepatitis. And then additionally, it's important to really wrap in the care for patients who are Hep B surface antigen positive, making sure those who are in need of hepatitis or of HCC screening are obtaining those ultrasounds at least every 6 months, making sure those who are non-immune are obtaining hepatitis A vaccination, naloxone for opioid overdose reversal, and continued and ongoing engagement for substance use disorder treatment. And so I'll conclude by really highlighting how we can improve upon hepatitis B care for people who inject drugs by overcoming some of these barriers. I think education of hepatitis B infection-related disease for both patients and providers, much as this format is providing, is really critical. Really being the advocate and arguing for advocacy for access to harm reduction, as well as increased funding for hepatitis elimination, will really overcome some of these economic barriers as well. Improving screening, diagnostics, and referrals to care are important. We know that just in the general population alone, appropriate screening and comprehensive diagnostic evaluation is still limited. So adding on the additional barriers in people who inject drugs is only exacerbates that. And then finally, improving access to treatment. Again, reducing those barriers from an insurance standpoint and making sure they have access to the best agents possible. And so I'll stop there. Thank you, and take any questions.
Thank you so much. That was great and really helpful overview. Any questions for this session?
I had a quick question, if possible. So do you have an idea of, obviously most of these injection drug users are adults, and we always say that 90 to 95% of adults spontaneously clear Hep B. So do you have a sense of, among injection drug users compared to perhaps non-injection drug users, is there a higher rate to conversion to chronic hepatitis B or a higher rate of more severe acute hepatitis B? Is there any kind of impact on their immune system that is associated with injection drug use, and is there data to support that?
Yeah, and that's a great question. I think what we commonly cite is that people who inject drugs and people who are chronic opiate users do have a relative impaired immunity. I'm not aware of the data to find the association with how many people then go on to develop chronic infection. Perhaps our CDC colleagues on the call have this data, but really there is that biologic plausible mechanism to potentially increase those percentages of people who ultimately go on to develop chronic, and particularly as younger and younger people are unfortunately being affected by opiate use and opiate epidemics, we may see a higher percentage of people going on to chronic as they're infected earlier.
Thank you. Yeah, I mean, I think if the data is not out there, it would be interesting to investigate like a comparison of natural history of Hep B and injection drug users versus otherwise healthy individuals. But yeah, thanks.
I think a similar question would be asking how many people don't respond to vaccination in the injection drug community.
Yeah, and I think that the same mechanisms can be invoked where we suspect that there may be slightly lower rates. And so in people who you're worried about not necessarily manifesting an appropriate response, one could do Hep B surface antibody titers following completion of vaccination to ensure adequate response.
I wonder if you could speak to challenges and overcoming challenges with adherence to treatment and really management in this population. I know that it can be a challenge to make sure people come back. And I'm sure we can talk more about this in the case as well. But if you have any suggestions for providers on the line who might see that in practice.
Yeah, I think that is, if only I had a solution to all of that. I think that's really one of the major barriers in retention and care. And I rely heavily on our care navigators and our social workers to have ability to reach out to patients and make sure that we're communicating at times that are convenient. We're reaching out to them using modalities that they can access. So text messaging instead of waiting for their phone calls, trying to engage them and really offering the opportunity to come in if they miss their appointments, come in for labs, try and re-engage them on any way we can. And if we just can't, really trying to support their primary care providers in completing the evaluation that we otherwise would in our clinic, and making sure that they have access to that treatment. Pharmacists as well really offer, in the lights of COVID pandemic, we've really become much better at delivering medications to people or their friends' homes to make sure that we can ensure continuation of therapy. So really using those tools in that toolbox to try and improve care and retention.
Myra, I see your hands up, feel free.
Dr. Jorgensen, thank you so much. This is really great information. What do you do when you have patients, you know, they come to us, they're very complex. They obviously have a history of substance use disorder, but if that's compounded by them having alcohol use disorder, I find that the treatment obviously is not going to be as effective. And, you know, the conundrum is now you have a patient who has active either Hep B or Hep C, and it's progressing based on the fact that they're using alcohol. I've had multiple patients who I put them on treatment, levels will drop, but because they continue to drink, you know, this is the issue. So I'm kind of, my focus has been, maybe I need to get them in inpatient care. Maybe I need to get them intensive case management. Like, I'd like to know what other people are doing in those kinds of circumstances.
Yeah, I think that's really quite common scenario that we see, and with these either co-occurring infections or syndromes where people have multiple reasons to have exacerbation and of their hepatic fibrosis from either hepatitis B, alcohol use, Hep C, or all together. And Myra, I think you really highlighted some of the key points is really meeting the patients where they are. You know, these substance use is their terminal illness if we're not managing it appropriately. And so trying to find out how we can support the patient to engage them in the care they need to prevent that ultimate outcome is really critical. Inpatients, wonderful. I think particularly for people who have opiate use disorder and alcohol, it's much more challenging if people are using cocaine or crack and engaging them or getting them linked into inpatient facilities is really challenging unless they're using as they walk through the door. So there still are a number of barriers to overcome there. We try and engage intensive outpatient programs as well. And again, with the lessons we've learned from COVID, Zoom is often available if people are unable or unwilling to go in person, but really trying to exhaust all options and really as, again, a multidisciplinary approach, engaging our mental health providers, peer counselors, and social workers to try and identify any other resources to tap into.
Great, thank you so much. Great question as well. Any other questions or comments?
Can I ask a very quick one, just for my knowledge? So TAF as PrEP, you said that it's not preferred. Can you clarify why? Just because there's not as much data for its use, or any particular other reason?
Yeah, and the concern is that there's high intracellular levels, and whether or not that's going to protect transmission from percutaneous routes is unclear. And so we have TDF-based PrEP trials in people who inject drugs. We don't with TAF, and there's a biologic concern that perhaps that would not be as protective as TDF. And again, as we have more and more options for PrEP with hopefully the new cabotegravir rilpivirine injectable in the next year, that may change how we really approach patients with Hep B and need for pre-exposure prophylaxis against HIV.
Thank you.
Any other questions or comments? Oh, Myra, go ahead. I see your hands up. Is that a new hand?
Yeah, I do have another question, and this may be more local, or perhaps others can chime in. In terms of the access to either Hepaslav or Injurix or Recombavax, or the new one, I'm having difficulty getting Hepaslav, and I'm wondering if with VFAR, which I'm also trying to get at our clinic, is that one of the medications that's available on the VFAR list? If anyone knows what that, if that's the case, vaccines for adults is a program that we use here in the city of Philadelphia to assist the uninsured and some who have certain insurances who are eligible for vaccinations that are paid for by the city. That being the case, I'm wondering what is the availability of that, and what's the cost if we had to buy it privately? Because I would like to make sure that if Hepaslav is better, and I'm hearing more and more, perhaps we should lean towards that.
I see Danica. I was going to say Danica would be the person I would ask, and I see her hand already up.
Hi, everyone. Myra, VFAR, my understanding is Hepaslav B can be ordered through the VFAR program. The request just needs to be made through the health department directly, but they will absolutely order that. The challenge is VFAR is a really good program in theory, except that now many adults have at least partial coverage from some payer, and so the VFAR program is only applicable to individuals who are completely uninsured. And so this is a huge challenge and a strange, gap that was made by what was supposed to be something that, covered people who did not have access. Hepaslav B is definitely more expensive. The total series ends up being more expensive than the other 3-dose options. However, again, deferring to Jesse and others, but you look at the immunogenicity that comes out of even just 1 dose with the Hepaslav B, and it seems to be have better coverage, and then after 2 doses, even the same. So the cost is there. Certainly, I believe it's well over $200 a dose. However, if somebody does not fit VFAR because they are partially insured, it should be at least partially covered. So if your clinic or organization could cover what remains of the out-of-pocket costs for the individual, those we know run, between $30 and I think we've heard over $50 per dose, which is just, a shame on the part of the payer, but it's far less in terms of, patient assistance if your clinic is able to support that. So it's not a straightforward answer. VFAR does cover it, but unfortunately that does not help everyone. In fact, many people are not covered by that. It's still a prohibitive cost for patients because of the out-of-pocket cost, but if you're able to provide some patient support to cover those out-of-pocket costs, Hepaslav B does seem to be a really good option for this population with this, short turnaround time between the 2 doses. Hope that's helpful.
That's very helpful. Thank you. Maybe that's something we can, maybe that's something the Hep B Foundation can take on as a movement as we're trying to eradicate Hep B. I know that VFAR did eliminate the eligibility status for the flu vaccine, and this is certainly another huge barrier that we could possibly overcome if we could get a similar type of reconciliation.
Yeah, I think that's a great point. And I would like to see if, Mark, if you're on the line, there's a new announcement, and I just want to kind of touch on it here and know that we'll be touching it more in the next year. But ACIP will be coming out with updated guidelines for universal vaccination between 18 and 60 for adults. And so hopefully with that will come better coverage for hepatitis B vaccination. It's going to take some advocacy on our part, but Mark, are you on the line? Are you able to speak to the recommendations and what we can expect with that?
Hey, this is Mark. Can you hear me okay?
Yes.
I don't have very much to add right now, just that we have the policy statement, policy note getting ready for publication, which we're aiming for spring, hopefully early spring by the latest. And that's sort of the universal adult recommendation for hepatitis B.
Great, thank you so much. And we'll be certainly featuring that and the implications that it will have for our primary care practices as well, and how we can work to expand and disseminate those guidelines widely in our spaces. Thanks so much.